Okay, so I wanted to say, while everybody's here, that how thrilled and happy we are here to have Dr. Green, the director of the Celiac Center, with us. He is globally known. His research is so important to what's been happening in the world today, and having him for one-on-one with us is stupendous. So I want to, without further ado, I'd like to welcome Dr. Green to start the program. We'll be asking you questions throughout, and thank you again for being here.
Thanks very much, Melissa, for inviting me. Yes, so tonight I thought I made some notes about some things that I would like to talk about to kick things off, and I'm certainly very interested in addressing any issues or questions that people have. We're just going to have our 20th anniversary gala in November, which is really quite a landmark. And we were looking to make a film about like the history of this. And I owe a lot, and everyone who's interested in the Celiac Center owes a lot to Sue Goldstein, because she really pushed me along to start a center. So Sue is here somewhere, I see, and so I think that we owe a lot to Sue, and we can talk about the Celiac Center a bit later on. So currently the estimates are that about half the number of people with celiac disease in the United States are diagnosed. Now, that's certainly a big improvement to what it was about 20 years ago, when only 17% were diagnosed. Currently it's about 1% of the population has celiac disease, and this is a very big increase from about 50 years ago. And there was a study done by Joe Murray that he took serum of young men going into the Korean War. So they were like 20-year-old white men in 1950, and then he took 70-year-old white men in Minnesota and 20-year-old white men in Minnesota, and showed that it had gone from 0.2% to 1% of the population. So there was like a five-fold increase over that 50 years. And it's been worked out that most of the increase in celiac disease occurred in the 80s and the 90s in this country. So back in the 60s, it was a rare disease, and now it's a common disease. And that increase correlates with an increase in autoimmunity generally. And we can talk about what some of the risk factors are that might be responsible for that. But only about 50% of people are diagnosed. So like, where are the other 50%? Now, some of them don't have any symptoms, actually. Some people with celiac disease don't have any symptoms, or they don't have the traditional symptoms that doctors might think of. Many of those people who have celiac disease might have started a gluten-free diet and noted a response and just stayed on a gluten-free diet, and so will never really be diagnosed. One of the reasons why people don't get diagnosed is they don't have typical symptoms. And even if you look at the risk factors, like look for anemia or look for osteoporosis or people with diarrhea, you're not going to pick up those people because they don't have those presentations. Another reason why the lack of diagnosis is lack of physician awareness. Like, we did a study of hematologists in the United States, got about 500 responses, and it's considered that anyone with iron deficiency anemia of any gender or any age should be considered to have celiac disease, but only 8% of these hematologists would screen anyone with iron deficiency anemia for celiac disease. So if specialists who aren't seeing a prime example of celiac disease don't consider it, it's understandable that people don't get diagnosed. In that study, it was interesting in that physicians that had more recently graduated were more likely to consider screening people. But we use that as an example of lack of knowledge of doctors to diagnose celiac disease, and lack of, and we can talk about like just general gastroenterologists and like patients determining what follow-up they have, like Mrs. Eisner saying, well, I have my antibodies tested every couple of years, like I tell the doctor what to do. So, it's hard to know how we can increase that 50% of rate of diagnosis in this country. And as you know, celiac disease can present at any age. And if you have the genetic risk, the risk of developing the disease doesn't go away. So like we typically will, I will ask patients, is your family been tested? And they say, yes, when I was diagnosed 12 years ago, all the family was tested, but they haven't been tested subsequently. So we would advocate that family members have the gene test, and we give out the cheek swabs, because it's terrible to make a kid, have a blood test when you can do the gene just from a cheek swab. So we will give out the cheek swabs, and people do the cheek swabs and send it into the lab, and then you find out if the gene is positive or negative. And what we look for, you look for both, but in a family in which there's an individual with celiac disease, about 20% of the offspring will not have the gene. So it's very reassuring that you don't have to worry about it if the gene's negative. But if the gene is positive, then we would suggest that people get tested every 3 to 5 years. And, I've been doing this for a while, so I've seen people in whom I tested them and they were negative, and then 10 years later, when they're a 23-year-old young man, they pop up with celiac disease, whereas like 10 years earlier, they were negative. So, in one study that we did in people who were at risk and tested, a mean of only 18 months later, the same percentage who were positive initially were positive on the second testing. So like the risk does not go away. And it doesn't matter what the risk is in the gene. It's either you have the gene or you don't have the gene. Because in a family, there are other risk genes. Like there are about at least 20 other genes that have been described, and they may be more prominent. Like we're very interested in doing a study now because we've got a company that will do whole genome screening for us. We're very interested in looking at families with more than one individual, and like them signing a consent, and like we'd send out containers and you spit in it, and then we can do like whole genome sequencing, which will find genes that have not been discovered. So if anyone is interested in doing that study, please contact me or Cynthia. We're doing lots of studies, and if you get our email, like you all should be getting our email. Oh, my Epic just popped up saying that I got to go. Excuse me.
You're there, we see
Sorry.
you.
Yeah, but I couldn't see everyone. So a mention about our research. Like all of you should be getting our emails from Cynthia, and if you don't, like, please let us know. Because we send out many questionnaires and we really need people to respond, because there's going to be no advances made unless people like step forward and participate in the research. If it's questionnaires, it's only going to take you 5 minutes, 10 minutes, and it really makes a difference that we get a representative population. So get our emails if you don't let us know, and please participate in any of our research protocols. So, like, as you know, celiac disease can occur at any age. And if you're at risk, if you don't have it at one time, you can have it at a later date. Like, we were very interested in, like, who here knows what ethnic group has the greatest rate of celiac disease in the United States? Anyone want to give me an example? Give me.
Italians?
No,
Nope.
no,
Is it Irish?
no, Barbara.
No, okay.
It's people from northern India, Punjabi people. Like, we did a study of about 500,000 biopsy reports, of which a certain percentage had celiac disease. Then we had an algorithm which would define ethnicity based upon the first and the second name. And we had average Americans, which includes Irish, Italian, and then, you can tell, like, Hispanic people, Asian people, Indian people, very precisely where they come from, Jews, and like the average American had a similar rate to Jewish people, but people from northern India had a nearly fourfold increased risk of having celiac disease. People from southern India was less. People from Southeast and Eastern Asia was less. Hispanic people in the United States was less. So, it was kind of interesting because many physicians think that Irish people are at increased risk, but there's just no evidence for that. It's just that people were getting diagnosed in Ireland more frequently. So it's any age, it's any ethnicity, but some have increased. And, children now present mainly one of three ways: with recurrent abdominal pain, with growth issues, or through screening. And the people that get screened are those that are relatives and kids with autoimmune conditions like thyroid disease or diabetes and Down syndrome. They're the main presentations for children. Amongst adults, still diarrhea is the main presentation because that's what triggers doctors to think about it. And then just having an endoscopy, typically for reflux, being anemic, having osteoporosis, or then a whole plethora of other causes. So, just like endocrinologists are very much aware, and like a study we did suggested anyone with any autoimmune thyroid disease should be tested for celiac disease, because celiac disease occurs so commonly in people with autoimmune thyroid disease. So there are a whole bunch of different diseases that somehow increase the risk of people having celiac disease. Any questions about any of this so far?
Anybody want to unmute and ask Dr. Green a question?
That's right. So, You know, the management of celiac disease is a gluten-free diet, and you're very lucky to have Melissa, because a gluten-free diet is not a healthy diet. And we've recently did some studies with the people in the School of Public Health in Boston at Harvard, in which we've had access to the nurses study, in which has been going on for like 30 years now, and it's about 70,000 people. And we characterize people as having low gluten or high gluten. These are people without celiac disease. And the people with low gluten had increased risk of heart disease and increased risk of type 2 diabetes. And that is because they don't typically eat whole grains. Like I always say, when people go on a gluten-free diet, there are two things. One is knowing what to avoid, and people learn that very quickly. The hardest part is knowing what to eat. And that's the reason why people have to see a dietitian, because the diet has to be healthy and has to be varied and has to include whole grains, etc. You know, it's not uncommon for people to gain weight and become obese, get type 2 diabetes, and then have this increased risk of heart disease. Like there's increased risk of heart disease anyway in celiac disease because of the chronic inflammation, and people get heart disease without the typical risk factors of hypertension or high cholesterol. Because people with celiac disease typically have low blood pressures and have low cholesterol. So just having inflammation increases the risk of heart disease and stroke. So like people say, you know, I get the doctor to check my TTG level and it's negative, so I feel really good about that. Well, we know that the tissue transglutaminase antibody does not reflect what's going on in the intestine. That just means that you're restricting gluten. It doesn't mean that the intestine is normal. So, you know, people, you know, and that test that you order has not been approved by the FDA for use in follow-up. It's only been approved for diagnosis of celiac disease. Now we use it in follow-up, but we know that if it's elevated, people are eating gluten. If it's normal, it doesn't mean that they're not eating gluten, and it doesn't mean that the intestine has healed. So that's one of the reasons why we would advocate a follow-up biopsy at some stage to document healing. Now, when people have, it's interesting, when people get biopsies, you know, they often don't get adequate pieces of tissue taken. Like there are guidelines, and I'm going to talk a little bit about the guidelines later on. So we don't think that a gluten-free diet is very healthy, and it's not healthy because people often don't eat whole grains. Many people with celiac disease and gluten-related issues restrict other dietary products, typically dairy, and then people self-identify as being intolerant to soy. You know, because of ongoing symptoms, people keep pulling other things out of their diet. You know, a gluten-free diet is typically low in fiber, and all the people in one study had elevated heavy metals, lead, arsenic, mercury, and urinary tin. And these were people on a gluten-free diet who didn't, American people, USA people, who were on a gluten-free diet, irrespective of their diagnosis of celiac disease. They had this increase in heavy metals. And while a lot of it was not in the toxic range, you know, to my mind, it's worrisome, especially for kids. And it's thought that it's related to all the rice that people eat, because like rice absorbs heavy metals from the earth much more readily than like other grains. And a lot of the rice is grown in places like that grew cotton and things like that, that for centuries, like people put stuff on the things to stop the bugs. So gluten-free diet is not a healthy diet because people restrict other things. They don't eat whole grains, typically low fiber, and increase heavy metals. And of course, you know, non-gluten containing flours are not fortified. So we would advocate that people not take a multivitamin, but have the folic acid monitored. And that's a very good parameter of if the diet is a healthy diet. Like, it's not uncommon for people to come in and say, I'm on a strict gluten-free diet, and they have a low folate. So, like, you know, we say, you might be on a strict diet, but it's not a good diet because you're not eating the foods that are rich in folate. And so we use that as a parameter of how healthy and how varied the diet is. So, which, as I mentioned, is to my mind harder than knowing what not to eat. So, yeah, and I mentioned the two studies that we did showing increased heart disease and increased type 2 diabetes. Any questions about that?
Yes, Dr. Green, I do have a question.
Yeah.
For people who eventually may need a statin for heart disease in the family or issues that it cannot be controlled by diet at some point, are statins a concern because of GI bleeding or theoretically even being on a gluten-free diet for so many years? Is there concern with the condition of a long-term celiac's GI situation in regards to ever needing a statin?
No. Like, what's common is when people get diagnosed with celiac disease, they have a low total cholesterol and low high-density lipoproteins. And then on the gluten-free diet, the bowel recovers and the HDL goes up. And then people often then develop high LDL levels, either because of dietary indiscretion or, you know, their other genes become more evident because they're not malabsorbing. So if people need a statin, there's no contraindication of having celiac disease as you know, being you know, a contraindication to using a statin.
Okay, thank you.
But you know, you need to make sure that, you know, your diet is a healthy diet.
Sure.
So I was going to mention about diagnosis because there's guidelines now in Europe for making a diagnosis of celiac disease without a biopsy. So, you know, I see lots of people with celiac disease, and unless the diagnosis was made according to guidelines, I always question the diagnosis. If someone comes in and says, I was told I haven't got celiac disease, I question that. If someone comes in and says, I have celiac disease, I question that. Because there's a lot of misdiagnosis, and the misdiagnosis can go both ways. So there are guidelines, you know, that in this country typically involve a biopsy. And I see people, you know, like a 20-year-old person who, like at age 10, were told they had celiac disease and they never had a biopsy. I'll always wonder if they really have celiac disease, because they didn't have it done by guidelines that, like, even now, you know, I see people that have like one blood test and they're told they have celiac disease. You know, the European guidelines for pediatric celiac disease diagnosis are like symptoms, a positive tissue transglutaminase antibody that's 10 times normal. And then the blood test that's repeated, because you can have temporary positive antibodies, or it can be the wrong blood sample. It can be like the next kid or something like that. So you need to have at least 2 blood samples separated by a period of time for the diagnosis to be made according to these European guidelines. And, you know, I see people with like elevated gliadin antibodies, they're told they have celiac disease. You know, they see very experienced gastroenterologists who say, oh, that positive tissue transglutaminase means you have celiac disease without question. Like, we've been very interested in this potential celiac disease in which people have positive antibodies but a negative biopsy. And if you follow a group of children that have positive antibodies, a negative biopsy, who like didn't have a lot of symptoms, maybe they were screened as family members, and a negative biopsy, we'd call that potential celiac disease. And this Italian study followed them for up to 12 years. And of this 300 kids, like 30% lost the antibodies and never had celiac disease. 30% just remained positive, and repeated biopsies, like every other year, remain negative. So they remain as potential, and then about 30% progressed to full-blown celiac disease. So, you know, people shouldn't be told they have celiac disease unless, you know, guidelines are really followed. And with adults, it's like typically people get diagnosed because they have the blood tests for some reason, and then they have an endoscopy that shows villus atrophy, and then they go on a gluten-free diet. Some people have the endoscopy and never had the blood test, and there are other causes of that villus atrophy, like they won't get better because it wasn't celiac disease originally. So we've been very interested in that population too. So, you know, I think that parents often, you know, want to protect their kid from having an endoscopy, but it can be very misdirected because the celiac disease diagnosis is forever. Recently, I saw a gentleman who used to live on Long Island, and then he moved upstate somewhere, and now he's moved to Florida, and I hadn't seen him for about 12 years. And he called up and said, you know, I want to make a telemedicine. Like, I've just had an endoscopy. I've been eating gluten, right? You know, not every day, but some days in the week, I've been eating gluten. And then I had an endoscopy that was normal. So I don't understand what's going on. So I got the biopsy and we looked at it, and it was in fact normal. And he had been eating gluten about 3 days of every week for like several years. So, you know, I said this actually might be very unique, and potentially you might have grown out of it. You know, he's now 60. He got diagnosed because his son was diagnosed, you know, about 20 years ago. And so, like I said, like if you promise to me you will follow up, I suggest you should eat a regular diet, and we do blood tests like every 6 months, and then arrange for you to have a follow-up endoscopy. So one always would worry about telling someone to eat gluten if they had a diagnosis of celiac disease, because they might eat gluten and then get a cancer later on that, like, I would be responsible for. So you know, we do see unusual things. And when you see like thousands of people who have this condition, you're going to find unusual things. I have seen 2 children that I think had grown out of the condition, actually. So it's exceptional. But like the children have not followed up, so I don't know what the long-term effect is. How are we going? Any questions?
Dr. Green, this is Linda talking to you on behalf of, hi, sorry, my camera's not working. Speaking to you on behalf
You
of
can
my
say that,
daughter.
but that's not true.
Sorry?
Nothing.
So my daughter was diagnosed at age 8 and she's now 21 in college. She generally does well, although I was worried about her last year. She had a situation with her health. And of course, when they're 21 and doing things, you know, independently, they don't always follow your advice. So from what you're saying, I'm just wondering, because she only had her first endoscopy and she hasn't had one since at initial diagnosis, should she have another one at some point now?
Well, I asked, like, is she being followed by anyone? And does she see a dietitian on a regular basis?
She doesn't see a dietitian on a regular basis anymore, but you know, since she went to college, it's been hard to get her to make her appointments and adhere to those checkups.
Yeah.
So she hasn't had one in maybe 2 or 3 years, I think.
Yeah. You know, like if I saw her, I would do some tests, right? You know, we do the celiac antibodies, and then we check, you know, first of all, is she having any symptoms? You know, we do check the antibody levels, because if they're elevated, particularly the gliadin ones, you know, the people are eating gluten, and would make an assessment about how she's doing, like get her to see the dietitian to make sure her diet is healthy and varied, and like probably would consider another endoscopy. You know, I see a lot of people who graduate from the pediatric part of the celiac center, and you know, sometimes, you know, I say, well, you know, are you interested in having a biopsy to see if all your hard work paid off and things are normal? And most people like want to have the biopsy to show that all their hard work is paying off. Some people say, well, if it wasn't normal, I don't think I can do any better, you know? So you got to respect what people say. You know, about 30% of people don't normalize their biopsy, right? And it's that group of people that don't normalize the biopsy that have the increased risk of the development of lymphoma, right? So,
Okay.
so I think it is worthwhile having another biopsy. Now, it's important that when the biopsy is done, that like adequate pieces of tissue are taken. That's in part of the diagnosis too, that, you know, like when people come along and bring the biopsy report in, like that says, oh, you don't have celiac disease, I look down and look at the number of pieces that are taken. Because in a study we showed was like, if inadequate number of pieces are taken, then there's a high rate of missing the diagnosis. So, you know, the amount of knowledge out there about this condition is really lagging amongst dietitians, nutritionists, and gastroenterologists. So many people feel reassured because they tell their primary doctor what tests to do, and or like, can I have the same tests that were done like a few years ago? So, you know, it's just important that people get followed up and they get followed by a nutritionist that is knowledgeable about the condition, so
Right.
that they're not only gluten-free, that they're healthy and minimize the risk of getting these other conditions. Now, like, you know, the rate of follow-up of children diagnosed here is not great.
Hmm.
Like, it is not great. And one study we did was the most important factor of young people getting followed up as an adult was if the pediatric gastroenterologist had made a referral to the adult gastroenterologist. That was the most defining factor of kids getting followed up into adulthood.
Okay.
You know, like people move away from home, right?
Yes.
They may not have health insurance. They have enormous social pressures. And, you know, they're free at last type of thing. So, you know, there's not a very great rate of follow-up, unfortunately. So I'm always interested when people do come along, because you don't know about those that are not coming along.
Mhm. What can I say to her that would encourage her to go to an adult gastroenterologist now? I mean, she will
Where is she?
graduate.
Where is she?
She's she's in Delaware at school there. We're on Long Island, but
Yeah.
she's at
Yeah.
school in Delaware.
I see lots of people, kids that went down to Delaware. There's a lot of people from New York area go down there. You know, you can just encourage people like to, you know, make sure they don't have any of the long-term sequelae of active celiac disease. You know, when people are asymptomatic, you know, I understand young people probably don't want to follow up, you know.
Right.
Like, you know, you should just encourage her that maybe she should come in to be seen in the celiac center.
Mhm.
You know, there are a few celiac disease centers in the country, and you know, like in the Northeast, you have you know, Columbia, and then you have the Boston, and then you have the University of Chicago, and then you have the Mayo Clinic. So there's a whole bunch, and then they're actually at Vanderbilt, they've started a celiac center. Like I think Duke now has a celiac center, so they're coming up, but still there are very, very few of them. So, you know, so it's easy for me to say that people should go to a celiac center, but like we have 4 adult gastroenterologists here, taking all different kinds of insurances. So there should be, I'm always interested when you follow people for a while that they kind of don't come back. You know, parents are very, like, we want to help you with the celiac center. And then when the kid grows up, then the parents like, don't worry about it as much, which, you know, you can't worry too much anyway, I suppose.
No. Well, I think I'm more worried about her than she is, because
Oh yeah, that's apparent.
she's had issues. Last year, she was very, very thin and wasn't gaining weight. And I wondered if her intestine was, you know, damaged again, because she was having, that was how we diagnosed her in the first place.
Well, this brings up another point. Like a lot of our recent studies we've been doing with Randy Wolf from the Teachers College. She's a professor at Teachers College, you know, an expert in nutrition. Like we're very worried about the development of abnormal eating patterns and the development of eating disorders. So in studies that we've done, like the young people who know most about it and whose parents were more like calling ahead, people who take their food when they go out, like not eating out and that, worrying about food all the time are like abnormal eating behaviors, and they're forerunners of anorexia nervosa, eating disorders. So like if I see someone who's underweight, I'm very worried about them. I'm very worried about like why they're underweight. Like they're either not eating enough because they got symptoms, or they got active celiac disease, or they got like an eating disorder. And, you know, eating disorders are more common in people with celiac disease than the general population. So
Right.
I don't want to increase your anxiety too much, but, you know, people should be encouraged. I saw a young woman just the other day in follow-up. I hadn't seen her for like 4 years. She made a telemedicine. Like we're doing this telemedicine now. It's astounding. I'm seeing people from all around the country. This young woman, she lived on Long Island. So there's no excuse, Lauren. She lived on Long Island and now she's down in the Washington area. And when I saw her 4 years ago, she had a BMI of 16. And I was very worried about her. She had a contraceptive implant put in and gained 30 pounds. And now she's got a normal BMI. So I
Wow.
can't explain that. But, you know, back then I had a seeing a dietitian and we were trying to work out why, you know, why she was so much underweight. But like we're interested in finding out like why people, so the studies that we did, the people that knew the most and were the most strict had the most abnormal eating patterns that were the forerunners of eating disorders. So we're interested in why that is. Is it the doctor? Is it the parent? Like the parent, you know, doing all the excessive, unnecessary stuff, like getting new utensils, only using certain plates, you know, having things just so abnormal, whether that's responsible for the abnormal eating behaviors, or whether it's the doctor, or whether it's the dietitian, or somehow the patient themselves. So, you know, like celiac disease has only recently come under the realm of physicians in this country. Like all the management was from support groups that did a good job, but they were occupying a vacuum. And it's only in the last 20 years that academic centers have sprung up. And like there's more research now in the United States than there is in any other country on celiac disease. And it's all coming out of certain centers. So like celiac disease has been uplifted, and it's taken a bit of time for the patients to catch up because, yeah, like they didn't have doctors that were interested, and it was all the support groups, and they often had misinformation. And people were doing their best, but often they were getting misinformation, actually.
Thank you.
I have a question about my daughter. I tested both of my daughters genetically when I found out I had celiac disease, maybe about 15 years ago, and they both had the gene for it. So periodically when they get blood tests, I would ask that they do the celiac test as well. And so they didn't have it a few times. But one of my daughters in recent years, she hasn't had a test maybe in about 6 years, a blood test, but she is now a vegan. She eats mostly raw food. She has a low gluten diet, but she found that when she ate seitan, she had a very strong reaction. And she went to
Satan.
Seitan, yes. Do you know what that is?
I only
the-
know the guy with the hat on and living.
It's
living down there.
Seitan. It's like a wheat gluten type
Yeah, I know.
thing. Yes. So anyway, but she went to an allergist and they said they thought she had maybe a wheat sensitivity or something like that. So she doesn't eat it anymore. But from listening to you, I really think she needs to get another blood test. I was hoping she wouldn't develop celiac disease. I nursed her
Okay.
for several years,
Yeah.
but
So
I know
mo-
that doesn't
most
make a difference
people-
now.
Most people who self-identify as being gluten sensitive are actually FODMAP sensitive.
Oh,
You know, if you do a double-blinded study, that it's the fructans in FODMAPs that cause the symptoms and not the gluten. So, but you know, like if she came along here, like we discuss her symptoms and that, get her to see the dietitian to make sure her diet is healthy and varied, because anyone on a gluten-free diet needs to have a dietitian help them to make sure that the diet is healthy and varied, because most people aren't trained as dietitians, and the diet isn't all
she is
that.
a dietitian, actually.
Yeah. Okay. So it'd be especially important for her to see a dietitian.
Mhm, mhm. Okay.
It's like
Just,
Can I ask a question?
gastroenterologists make the worst celiac patients too.
I would bet.
just one thing on the seitan, what that is, it's the gluten that's in, when they make seitan, it's basically you take wheat flour and you run it under water until you only have the gluten left. So it's pure gluten. That's what that is, that the seitan. They make a lot of the vegan meat products out of that. And
Right.
you can see that, like, the fake hot dogs and the fake bologna and things like that.
Yeah.
So that's
Like
probably,
one of the reasons for the increase in gluten, increase in celiac disease in the 80s and the 90s is thought that maybe it's all the vital gluten that was being added to food, because like there's been no change in wheat for the last 100 years. The amount of gluten in wheat varies with the rainfall and the quality of the wheat. Like white bread has had vital gluten added. There is possibly a lot of vital gluten added to foods, and maybe one of the reasons, contributing factors to the increase in celiac disease is the amount of gluten that's consumed, actually. So that's very concentrated gluten, but I don't know, Melissa, would there be other FODMAPs in seitan?
well, sometimes they flavor it because it's just the gluten. Sometimes they boil it and simmer it in different types of things. So there might be a lot of garlic, there might be a lot of onion extract and other types of extracts that are high FODMAP in it. So it could be that because gluten is just harder to digest and it's such a strong amount of gluten, or it could be because of what they flavored it with. It could be either way. It's hard to say, if it's, so does she have celiac disease, or does she have a FODMAP intolerance, or was it just total overload on things that are hard to digest?
Yeah, sure.
Have to bring her in.
Can you talk about the tests that are necessary? Like if you had your doctor run some tests, because the last 2 times I had asked my general practitioner, they order from Quest a celiac disease panel, and it had the tissue tranglis. I don't know how to say that. TT.
Yeah, TTG.
Okay, and immunoglobulin and endomysial antibody, SCR.
Yeah, that's not a good test. That's not good. But that's someone who's diagnosed and trying to get follow-up. Why don't you go to someone who knows what test to order?
I'm seeing you now.
Who's this?
Kathleen
yeah.
Ticcarelli.
I saw you the other day.
I just spoke to you a week ago.
Yeah, I know.
Yeah, but I'm.
You're in a different room than you were last time.
Yeah, I'm right here. Okay.
So,
Well, yeah, those were the past.
So the tests that we use are the TTG IgA and the Gliadin IgA and IgG. you see, you don't need to do that total IgA every time. The endomysial antibody is not sensitive or specific in follow-up, you know.
Oh, it's
So
not. Because I had it negative. Mine showed that it was negative, so that doesn't mean anything.
that runs away. Like you think of gluten-free and that test runs away, becomes negative. Some people's antibodies like melt away when they think of being gluten-free. Other people can be very, very strict and the antibodies not go away. Like we don't know how sensitive any one individual is to small amounts of gluten. That's why the tissue transglutaminase is known like to not reflect what's actually going on in the bowel. People have been like taught to, oh, my antibodies are negative. So, you know, I say, oh, yeah, that's good. You
So
know,
they
that-
shouldn't be running this test, this panel that just says celiac disease, a comprehensive panel.
no, that's useless.
That's
The
useless.
TTG IgA. See, it's a very expensive test that because that total IgA is expensive and the endomysial antibody is an immunofluorescence test that's complicated to do. That's an expensive test. And one
Yeah.
of the developments have been the ELISA tests that are inexpensive. So, you know, and it's confusing for doctors because there's like the celiac panel, the celiac deluxe panel, the concierge panel, you know. And like it's so it's confusing, but there are these specific tests, and then like there's a very bad test out there. That's this TTG IgG test that just doesn't mean anything for celiac disease.
Now you ordered for me, I didn't get it done yet, but gliadin peptide AB, comma, IgA/IgG. So what is that? That
That's
you
the
ordered?
gliadin IgA, IgG.
So in the future, if I'm not here or whatever, if I have to talk to another doctor, they have to order that as a follow-up?
That and the TTG IgA.
Just those two? Because
The
that's all you
gliadin-
had me, that's all you're having me do.
Yeah, because you've had a TTG IgA. So the gliadin IgA and IgG. So
Yeah, and I had the TTG last April. You're repeating it because it was on the border. It was 4. And anything 4 or above was abnormal.
yeah. So I want to talk a little bit about our celiac center. So it's been, we're having like the 20th anniversary, and like all our activities have been funded through the generosity of donors. And like we have these 2 dietitians now, and we were not, like when we were billing patients to see the dietitian, no one would see them. So now we don't charge, but we support all their activities, like their salary, you know, the telephone charges that we pay, the rent on the closet in the hallway, etc. So part of the money that we raise like goes to the dietitians for the nutrition program, but the bulk of it goes to research. Like we have a biobank. We've had 2 separate labs, and actually the Celiac Center has been at the top in the world actually of research coming out. And it's only through research that things are going to get better. Like currently we're involved with 7 different companies that are looking to produce medications to help people with celiac disease. And so, you know, I can predict that in the future, there's going to be medications to help people, and then some medications may like allow people to eat a regular diet. And, you know, to my mind, people with celiac disease have had to suffer from not having a therapy. Oh, it's just the diet, and it's become increasingly difficult for it to just be the diet that that manages the way to manage celiac disease, because it's very easy for some people, but it's very hard for some other people. And like, I think the cost with these eating disorders and abnormal eating behaviors, and the stress of those, like, can be very great on people. So I think that it's been a shame that the diet has been the only therapy that has been very effective, that delayed the development of a medication to help people. So I can really see that, like, in the future.
So how do you think the medications are working along, by the way? Because I know that people in this group are very probably curious to see where that looks today.
Yeah, so, you know, currently we're enrolling patients in 2 different studies, the enzymes and another group. That, like, we've got to have people volunteering, and you know, otherwise they're not going to get done. And the people who we need are people who have some kind of symptom, because the FDA says you can't, you know, get a drug on the market that doesn't make people feel better. Like, we were very obsessed with just having the biopsy better, but the FDA says people have to feel better too. So we can't enroll asymptomatic patients in these drug studies. So there'll be medicines, and like, I can predict people are going to get like an injection every couple of months and be able to eat gluten. You know, it's going to be like groundbreaking after a while.
Dr. Green, this is Dottie here. I have a question. I was diagnosed 25 years ago, approximately, had a high atrophy, villus atrophy. And oddly, I just got something in the mail about 6 months ago. I don't know how accurate these 23andMe tests are, but it states that I have 0 variants detected in HLA-DQA1 and HLA-DQB1 genes.
Yeah.
Could that be possible?
Yeah,
Still have a,
it doesn't
you know,
detect a variant. Like, we have just done a big study with 23andMe, because, like, there's more celiac disease in the northeast of the United States, and we had thought that was maybe because there are more people with the genes, but they're actually distributed evenly around the United States. So that's not the reason for the increased rate in the northeast. That's both diagnosed and undiagnosed. But 23andMe does not detect all the genes.
so it's not accurate.
It's accurate if you've got the genes, you've got the genes, but it doesn't detect all of them. So
Okay.
all they can say is you don't have those genes that are responsible for the bulk of people with celiac disease.
But I still have celiac disease. That's what you're
If
saying.
you had it,
Mhm.
if you
So
had it,
you just said I had it or I have it.
well, if you were diagnosed along the grounds, like if you had the if you had the antibodies and you had the villus atrophy, and then
Yes,
got better on a gluten-free diet, you more than likely had celiac disease.
yes. And I still have, is what you're saying.
Yeah, if you had it.
Yes, okay. I thought it was odd. I didn't, for
Yeah,
this to
well,
pop up.
like that, so you might question whether you do have it. So
Correct.
you can question it and then come in and let us determine.
Okay, yes,
So you're not going to find a better way to find out if you've really got it, because we saw a lot of people with villus atrophy
yes,
that got better. Like, if you didn't have the antibodies and you had villus atrophy, only some of those people have celiac disease. Like, we would not put you on a gluten-free diet because you can get better without going on a gluten-free diet if you don't have celiac disease.
mhm,
So like it's very reasonable you getting that genetic result to question whether you've actually got it or not.
Okay. I did see you a couple of times though, when I first was diagnosed.
Who is this?
This is Dorothy McDermott, but this was years ago.
I'm still here.
Okay. Good to see you.
That's Dottie?
Yes,
Okay,
yes, I did see you 2 or 3 times.
okay. So, you know, like I saw that other gentleman and he's now eating gluten and we're going to see if he's really got it, because most people are told that you don't grow out of it and you still have it. So,
Yes,
like, you know, maybe not everyone does. Like if everyone stays on a gluten-free diet, you don't find out if some people like lost like that potential celiac disease that we talked about, in which people lose the antibodies and never have villus atrophy. That's a unique group of people. They were intolerant in an immune way to gluten, and then they lost that intolerance. They then tolerated it. So, like anything goes. You know, it's exciting to try to determine that. But the simple thing to do would be to get that gene test done. Again, that'd be the first thing that I'd do. I'd do it at a commercial lab.
okay, so if I called you up, you could send me a script for that?
Not without being seen. If I haven't seen you for,
Like
because I can't see your face here. You're
I mean, a video consult.
yeah, that'd be fine.
Yeah, okay, good. I'll do that.
That'd be great. Yeah.
Thank you.
Oh, well.
You know,
Dr.
Dr.
Green.
Oh, you go first.
Oh, I'm
Sorry.
sorry. I'm sorry, Dr. Green. This is Jacqueline Parenti. I just have a quick question. I was just diagnosed with celiac from a biopsy with an endoscopy about a week ago. And so I'm very new to this. I have joined support groups on Facebook with, you know, and everybody's got all different
That's of
types.
questionable value.
Yes, I agree. I
Like,
agree.
I think you might get a lot of misinformation. You hear the worst of the worst. So I like actually Ann Lee did a study showing that people that used like social media had a worse outcome.
Okay.
actually.
I heard you mention something. I don't know if there is medication on the market, but I guess because I'm very newly diagnosed, the pain and the discomfort, you know, are there things to take to make, like, I mean, I live in a family of 3 kids that the cross contamination, you know, we try to limit it as best as we can. I mean, it's only been a week. But you know, a lot of times very nauseous, a lot of stomach pains, and it's just like learning things. So, I mean, is there anything that I can
sometimes
do?
like people who are very sick might get some of these locally acting steroids. The pains might be due to like lactose intolerance or due to bacterial overgrowth or you know, there are many reasons why people have symptoms, and it can take some time. Like usually symptoms get better first, but maybe you need to be seen by me or one of my colleagues here because, you know, there are some therapies, you know, and like, you know, the way you get looked after now is going to determine how you are in, you know, a few years.
Right. I'm just gonna actually, there's a car next to me that's making a ton of noise, so I'm just gonna roll the window up.
Yeah.
But I know, like, I mean, we had a sporting event for my child, and I went to 2 or 3 different restaurants, and nobody could serve me dinner, and they all.
You should be able to do that. You see, like you should be able to eat a gluten-free diet at an average restaurant. Like Anne would tell people, you know, like I'll have some meat, I want you to cook it on a bit of foil, and I want it to be naked. You know,
Okay.
then I want you to boil a potato for me. You know, that's extreme, but you know, like I eat out with people who have celiac disease, and in any restaurant, you should be able to get a gluten-free meal. You don't have to go to restaurants that are dedicated gluten-free. It might be more reassuring to people, but you don't really have to do that.
Okay. Okay. And where are you based in Manhattan?
We're in California.
Oh, well then I can't see you.
No, I'm bullshitting.
Always
That's-
teasing you.
I'm-
Oh, well,
yeah, it's still Manhattan, like 168th Street.
okay. So you're still in the city. Okay.
You know,
Okay.
Dr. Green has a lot of, the Celiac Center has a lot of support programs also to help people that are trying to live gluten-free. I know that, Cynthia, are you able to unmute? Are you still with us?
She's been
Oh.
sitting here saying you've got to finish
Hi,
it.
Cynthia, tell them a little bit about the cooking program that you've had, that you put
Yeah,
together. 'Cause I thought that was
so,
fabulous.
Yeah, so we have lots of different activities, including a cooking program, which Marissa just mentioned. We do it basically every month or every 6 weeks. And if anyone's interested, you can email me and I'll invite you as a guest at the center. The next one is on Sunday, October 17th. That's this coming Sunday. And we do have openings. So anyone that's involved tonight, just email me if you want to come as a guest to the center, and I'll send you the invitation. And if you accept, then I'll send you the list of ingredients that you have to purchase. And it's a really, really fun 2-hour program. And I don't exactly know what we're making, but I think it's something really fun and then something really healthy.
You
So,
should share your email address with everybody, just.
so
so
my
you can get-
email address, very good, Marla. So my email address is C as in Cynthia, B as in boy, 2280 at cumc.columbia.edu. So it's cb2280 at cumc.columbia.edu.
And like you can say, just email her to get on our email list
Yeah,
so that you know about all our activities and our research and our parties, because they're going to start up again soon.
yeah. Our
We
gala.
have wonderful, wonderful
Yeah.
things.
Sorry, just one more thing. Our gala is November 11th, and we also have an educational program that's going to be virtual. It's also free of charge, and it is January, I think, 20 or 21, something like that. But if you email me, we'll add you to the list, and you'll start getting all these announcements for our center activities.
Yes, Melissa has been very supportive of the Celiac Center, and I actually appreciate the opportunity to talk to everyone and like share some of the information that we have.
A quick question,
Yep.
is the cooking thing a Zoom or is it an in-person?
No, it's a Zoom.
It is
Everything that we're doing now is virtual because of COVID, and we'll
Right.
continue to do so until it's safe for everyone to be together again.
The university's got
It's also
guidelines
easier
for
for
it.
people who don't, who can't get into Manhattan, so it works for both with something like this. Thank you.
Welcome.
Some people do regard it as being as far as California. Okay.
Dr. Green, I have one other question. For people like myself who have a child who carry the gene and are currently negative and no symptoms, what could be done to keep them that way forever?
You could like not let them eat gluten forever, and then they'd never get celiac disease.
Well, that's
That-
true, but that's
they-
not
they-
recommended, right?
No, they'd hate you. They'd hate you forever. Like the most important thing is that the kids eat a regular diet, and like the one study, the big study of like 1,000 at-risk kids, the ones that were going to get celiac disease got it all within the first 5 years, right? And then like they're the heterozygotes, the one with a very strong dose of the gene. But we see people, you know, I see people at age 21, age 30 develop it, etc. So, you know, it's not unreasonable to do the antibody tests every 3 to 5 years and just be aware of if they got symptoms that it should be considered as part of the diagnosis. So there's not a delay in diagnosis.
And is there a concern, like last year I kept my son remote for school because I had a concern that if he was exposed or had gotten COVID, that perhaps it could have tripped on the celiac, like
Right.
mine was tripped on by a viral illness?
Yeah,
Is there,
people with celiac disease are at increased risk of a whole bunch of infections. So that's why we always talk about vaccinations. Like we check that the kids have hepatitis B antibodies because often with celiac disease, they didn't develop them. There's increased risk of bad outcome with the flu. There's increased risk of pneumococcal infections, and there's increased risk of shingles. So we talk about those vaccinations all the time. Now, we've done lots of research with COVID. People with celiac disease do not appear to be at increased risk of COVID. They do not appear to have worse outcome. And this is studies done here at Columbia and internationally. So there's no increased risk and there's no increased risk of worse outcome. Like there were no more deaths or intubations in people with autoimmune conditions here compared to those that didn't have it. And there's no increased risk of adverse outcomes from the vaccination. So
is there any increase though that you've seen for, let's say, children who carry the gene but are not currently celiac? But
how would
get
we know that?
COVID?
How would you know that?
Right. I
The-
guess,
the
right,
bad outcomes with kids is so rare.
right. Not for bad outcomes, but for exposure to COVID being,
There's no knowledge about that. That's
Trigger?
like,
no,
who knows who's got the gene or not? Like
Right.
no one knows that.
Right.
All right then. So I'm gonna head off.
Dr. Green?
now. Yeah,
Hello, this is Suzanne, Dr. Green.
yeah. One more question then.
Okay, I was diagnosed almost 40 years ago.
Yeah.
How often would you do the endoscopy? And everybody always says you have to eat the gluten before. I
No, you
refuse
don't
to
have-
do that.
Like if you've had celiac disease 40 years, like there's no indication to do the endoscopy unless symptoms change or symptoms develop or you're having an endoscopy for another reason. Like,
I haven't
yeah.
had one for
yeah, of
I don't know,
course
about
not.
8 years.
There's no indication to do it unless something has changed or you're having the endoscopy for another reason.
Okay, good.
Yeah.
How often do you find that lactose intolerance goes along with it?
It's very common, you know, maybe about 20% of people are lactose intolerant and some of those are going to get better after going on the diet.
Yeah, no, it's increased over the years.
Okay then.
So we
goodbye.
want to thank you, Dr. Green, for being with us today. We recorded this and I'll be putting the information on the Facebook page, Gluten Free of Long Island site. So we'll have that there. We'll share that with
Melissa,
you.
thank you very much for inviting me and keep doing the great work that you're doing.
It's really wonderful to have you. And I'm just, you know, after you just go off, I'll make the announcements about our next meeting. And thank you, thank you, thank you. I know a late night. Thank you.
thank you, Dr. Green.
Thank you.
Thank you.
Bye.
Thank you,
Kathleen.
Dr. Green.
Thank you,
And
Dr.
Shireen, bye.
Thank you, Dr. Green.
Thank you, thank you. Thank you.
Thank you.
Good to see you again. Thank you.
So we will be having Ann Lee from the Celiac Center, the dietitian that he spoke of, next month in November 10th at a 7:30 call, which I'll put the information out. We'll have it on our website. We'll send it to on an email, and I'll put it also on our Facebook page. I put in the chat Cynthia's email address, and I put a number to text me if you can't get the right email to Cynthia, and I will get back to you, make sure that she gets your message if you want to be in that cooking class. Thank you all for being here, and we will be posting this, putting it up on a YouTube and then give you the link so you could watch this at another time. Thank you again.
See you
Thank
soon.
you.
Thank you so much.
Good night.
Good night.
Thank you. Bye.
Good night.
Good night. Thank you.